Hello, my name is Sean Reddy. I'm an Advanced Esophageal Fellow at the University of Michigan in the Division of Gastroenterology. On the behalf of my co-authors, I'd like to spend a few minutes discussing our manuscript entitled The Clinical Impact of Routine Esophagram After Peroral Endoscopic Myotomy. This was a multi-center study that involved collaboration between the University of Michigan, Medical University of South Carolina, and Johns Hopkins University. Peroral endoscopic myotomy, or POEM, has rapidly evolved as an effective first-line treatment option for patients with achalasia and can sometimes also be considered as a treatment modality in other spastic or hypercontractile esophageal motility disorders. POEM has been shown to have a favorable safety profile, but serious adverse events can occasionally occur, with the most notable being postoperative esophageal leak. As a result, obtaining routine contrast esophagram, even in well-appearing patients on postoperative day number 1 to identify adverse events has become a common practice amongst many centers. As most POEM endoscopists know, the frequency of esophageal leak is very low, and several incidental findings on esophagram can be found which do not alter the clinical course. However, there's a paucity of data evaluating the practice of esophagram on postoperative day number 1. Thus, many endoscopists continue to obtain a routine esophagram as part of their post-POEM algorithm. To provide further clarification for the role of postoperative esophagram, we sought to correlate esophagram findings of impending or confirmed leak to the clinical outcomes of patients after POEM. We also aimed to better understand the full spectrum of esophagram findings after POEM. We studied a total of 170 patients who had previously undergone POEM at one of our 3 study institution sites. The data reviewed include POEM procedural details, post-POEM day number 1 esophagram findings, and the immediate postoperative clinical course. All of the esophograms had been obtained on a routine basis regardless of clinical scenario in order to preemptively rule out esophageal leak or tunnel dissection. We collected several covariates of interest, with some of the most pertinent being intraoperative adverse events, postoperative day number 1 symptoms, postoperative adverse events, and the need for repeat procedures. Almost a quarter of our cohort experienced an intraoperative adverse event, but the overwhelming majority of these were self-limited or immediately resolved intraoperatively and did not prevent successful procedural completion or result in changes in the postoperative course. Postoperative symptoms occurred in less than half of our patients and did not correlate with the presence or absence of abnormal esophagram findings. Radiographic abnormalities on esophagram, which in many cases can be expected post-POEM, were noted in approximately 60% of our cohort, most commonly on CT-based compared to fluoroscopy-based esophagram. But relevant results of leak and/or dissection were only found in approximately 3% of the total cohort. There were 4 patients who had significant postoperative events of dissection or leak, equating to about 2.5% of the cohort. In 2 out of these 4 patients, the esophageal leak was discovered based on clinical deterioration, as prior postoperative esophagram imaging earlier in the course did not detect an obvious leak. Conversely, in 1 patient who was doing clinically well, finding of esophageal leak on postoperative esophagram prompted repeat endoscopy where no abnormalities were found. Additionally, in the 4 patients who developed an esophageal leak, there was no clear pattern of having preceding intraoperative adverse events or postoperative symptoms. Our study demonstrates the potential pitfalls of immediate post-POEM esophagram by showing examples of patients with false positive or false negative findings of esophageal leak. The former leads to unnecessary repeat procedures, while the latter fails to identify significant adverse events until the time of clinical deterioration. These observations noted at multiple sites within our study expands upon prior reports from single-center experiences. The questionable accuracy of post-operative esophagram compounded with the low significant adverse event rate amongst experienced POEM endoscopists suggests that it is difficult to rely solely on routine esophagram for detecting postoperative adverse events. Therefore, our group favors the use of a combination of intraoperative factors and clinical course to complement radiographic findings when making decisions. Further large-scale studies could build upon our findings with the aim of identifying accurate predictors of post-POEM leaks to learn how to better tailor the ordering of imaging. We believe that this would ideally promote a highly accurate algorithm based on a combination of pertinent predictors allowing for selective rather than routine use of esophagram in those patients felt to be at the most high risk for developing significant postoperative adverse events. We'd like to thank the editorial team at Gastrointestinal Endoscopy for the opportunity to showcase our work and genuinely believe that our findings will be of interest to the viewership. Thank you.